AZCCC presents the Cancer Care Podcast, Arizona Center for Cancer Care. Comprehensive care with the highest quality of cancer treatment in Arizona. Joining us today is medical oncologist Dr. Arun Singavi.
So why Arizona?
I'm a Midwestern kid. My wife is from California, and the snow doesn't really work out in the Midwest for a California kid. So we were looking for moving out west, and I was looking for a practice that embodied what I really wanted to do, which is just take care of people. And I found that at AZCCC in Phoenix, so that's why I came here.
What part of the Midwest?
I'm from Plainfield, Illinois.
All right, and the wife is from what part of California?
Huntington Beach.
And that's pretty.
It's a big move.
And both of you said Phoenix?
We were looking for Phoenix because it's a growing population. I'm in the East Valley, so lots of families. Within just a few months of being here, we were able to make lots and lots of friends and put our roots down, I feel like.
So I know this is an elementary question, but we have all types of different listeners who enjoy these podcasts from AZCCC. And a lot of the listeners, they don't really have a medical background. Mm-hmm. So let's just start off with explaining what a medical oncologist is.
Fair enough. So most medical oncologists are most likely also hematologists. So you'll hear hematologist, oncologist, or medical oncologist and hematologist. We are the quarterback of the team, so to say. When you come to see a medical oncologist with a new diagnosis of cancer, that's most likely going to be your point man. And we're going to direct your care saying, hey, these are our different treatment things that we're going to do, whether that's radiation, surgery, and we're going to guide you through your journey, including when we're done with all the treatment stuff, monitoring to make sure we're never dealing with this again or catching things before they cause us problems.
So when a patient comes to you, they've already been diagnosed?
Most of the time, yes.
But not all of the time?
Not all of the time. Sometimes there's just something suspicious.
Okay. So really, you're the first entry point of their care.
Yes.
Deciding what type of treatment they're going to get.
Yep. Yes.
So when a patient first comes to you, let's kind of walk through that first visit. Can just imagine a patient coming in, they're scared, they're nervous, they may or may not have a loved one with them. And the first question they probably ask you is, Doc, what do I got?
Yeah,
right?
I think the first visit with an oncologist is nerve-wracking. You may or may not have just been told you have this particular cancer, and the diagnosis of cancer, it carries a lot of connotations with it. And patients, family, friends automatically associate it with this image of chemotherapy, illness, death. Somebody's just wasting away. We've come a long way in cancer detection and treatment. Quite often, it means none of those things.
So their mind automatically goes a little bit dark because they're in a scared position.
Yeah.
They've just been diagnosed with cancer. And they probably know loved ones or family members that have had cancer with whatever result. And that's basically what they're most concerned about is the outcome.
Yeah, I think there's that overall feeling that picture brings in your mind at that first oncology visit. And there's a lot of information provided in that first meeting as a doctor, and I say patient, but I include family in that because cancer is not something you're going through alone. You're going through with other people, and they're going through it with you.
Is it hard to communicate with them? Because when somebody's scared, and it's like deer in the headlights, sometimes they only hear what they want to hear, or maybe unfairly, they've already been on the internet looking at information that is true or false, and you have to navigate through that.
Google is the worst. At the first visit, you'll hear me tell patients, don't go to Google, because Google will drive you down a rabbit hole where some rare thing is happening and you're dead tomorrow. That's not the case. As I said, we've come a long way. That first visit, they are in shock. Their mind goes blank hearing that word cancer. And that's why I think it's important to have family members there. And during this pandemic time, I usually have somebody on speakerphone, or if a loved one's coming in with them, I have them come in so we can write down stuff and we can go through things with you.
So during our conversation right now, you're using common language like you and I are just hanging out and the average person can understand. How difficult is that when you're discussing cancer with a patient without using this medical verbiage that is foreign to them?
Honestly, I don't think it should be. I think my job is to make sure you understand what's going on with you on your terms. We have to make sure that once you understand what's going on with you, the treatment that we're talking about also makes sense. But obviously, words slip out where it might not make sense, and patients might be embarrassed or too in shock to ask questions about it, which is why I wanted to talk to you about how do we navigate that first visit today.
Tell me about that.
When the diagnosis is made, first question I always get asked is, okay, we've got this diagnosis. What stage am I?
I don't really understand what that means. I know the higher the stage, the more at risk, correct?
That's correct, yes.
But how do you define the different stages?
Staging means different things for each cancer. I think a good way to do this is dividing cancers into blood-related cancers, which are like your leukemias, your lymphomas, and dividing them into solid tumor cancers like breast cancer, lung cancer, prostate cancer. Blood cancers, as I said, are your lymphomas and leukemias. Because blood goes everywhere, these cancers can show up in multiple areas. And stage 4 doesn't mean the same thing as it would for something like stomach or lung cancer. Now, thinking about the other side, stomach, lung cancer, or breast cancer, we broadly stage these using 3 criteria. So one is, what's the size of the tumor? Has it spread to the lymph nodes? Once it's spread to the lymph nodes, typically that's going to be stage 2 or stage 3. Then has it spread to any other organ outside of where it started? That's going to make it stage 4, or when we say metastatic disease, meaning again, it's left the site where it started and gone to another organ.
Okay, so as an example, just talking about the difference between a solid tumor and a blood cancer. With solid tumors, if somebody has lung cancer,
yes.
All right, stage 1 would be that you spot a tumor.
Exactly.
Stage 2 would mean that it may have entered the lymph nodes. Stage 3...
maybe some of the farther lymph nodes.
And stage 4 would be metastasized, as you
exactly.
call it.
Exactly. Metastasized, another organ that wasn't where it started from.
And depending on the stage is the treatment that you recommend.
Exactly. So which is why staging is so important, to figure out what are we starting with.
So if it's a stage 4, would it almost always be a chemo type situation, because it seems like it's spread throughout the entire body?
Most of the time, yes. If it's traveled to somewhere else outside where it started, it probably used the lymphatic system or the lymph node system, or it used the bloodstream. So I've got to use something in our toolbox that goes everywhere. That doesn't mean that we might not use other treatments as well, but there's going to be some sort of systemic treatment.
This is fascinating. If a stage 4 is metastasized, and you said most often it might be a chemotherapy situation, but I've also heard of people with stage 4 getting radiation. Why would that be so targeted?
Good question. So stage 4, nowadays, especially over the last 4 or 5 years, we talk about stage 4 disease, and there's stage 4 where it's in multiple different organs, or sometimes there's one spot in the liver. Well, then it's only one spot that we can see. Maybe we should treat this how we would treat a stage 3 for everything else, and then go after that one spot with radiation or even surgery.
Okay, so we went through the 4 stages of solid tumors.
Yeah.
Going back to what you said about the blood diseases, how do the stages differ there?
So we typically think about lymphomas for staging for blood type cancers. Those are cancers where we look at, on a PET scan most likely, which lymph nodes are lighting up. Or are we seeing it in organs? Because they can go to the organs as well. And that tells us how many lymph nodes are we looking at. And based on the diaphragm, so in the middle of your chest, is it above or below that? So are we seeing spots on both sides? If we are, typically that's a stage 3. If it's showing up in your bone marrow or in another organ, then we think about stage 4 for those. But the difference is in the blood-related cancers like lymphoma, a lot of those we're still treating to try to get rid of the disease or cure the disease with good success.
So stage 4, I know it's the highest risk, but is that pretty much getting to the point of just making somebody as comfortable as they possibly can for the time they have left? Or can you be even more positive and say there might be a chance that we can overcome this?
That's a great question. I think stage 4, depending on what type of cancer we're dealing with and how much disease is there, There's a lot of reasons for hope, especially over the last 10 years. And I'm very excited for all the treatments we're going to have over the next decade. So stage 4, no, it does not mean you're done for, we should pack up everything and call it. Stage 4, there's a lot of treatment options available for those patients. Granted, for solid tumors, the majority of time, we most likely can't cure this disease, but we can treat it, buying quality time. And I emphasize quality time, meaning I want you to enjoy the time you have, however long that might be. And for a lot of tumors, it could be many, many years.
So can I ask you a question I've always been curious about?
Yes, please.
There's a lot of different stages that people get diagnosed in. And we always hear that the earlier you catch a cancer, the better chance you have at treating it, which makes total sense. The majority of people who get diagnosed, do they originally get checked because something's off, they don't feel right, maybe they're in pain, maybe they see something growing, or is it through just a general physical that they take and they don't even know they're sick?
Unfortunately, it's because they have symptoms of something.
So you're going to find it later.
Yeah, most of the time, except for colonoscopies. Screening is so important. The idea of these screening tests that we do, like mammograms, colonoscopies, PSAs in the appropriate population, all of those things make a huge difference, because the idea of doing a colonoscopy is, hey, we did find a cancer, but it's early, it's stage 1. We already took care of it for you when we were doing the colonoscopy. Now we'll just do another colonoscopy in a year to check you out.
So the thought is you want to catch that solid tumor before it gets to the lymph nodes.
Yeah.
In stage, okay.
As small as I can get it, that's when I want to catch it. There's research now in trying to detect it in your blood before it even becomes any sort of visible size.
Is a medical oncologist the one who typically has to have the tough conversation of, you know that you've been diagnosed with pancreatic cancer? We need to discuss more because it is stage and it could be a 4. Are you the one that has to have that conversation with the patient?
Yeah.
Oh, how do you do that?
I think it's a privilege. The most wonderful thing about being in medical oncology is I very quickly get to be part of your family. And my job is to guide you through whatever's going on with you, whether that's stage 4 pancreatic cancer. I'm going to be with you every step of the way, and I'm going to guide you through that. And if my conversation is, hey, things don't look good, we need to talk about how do we best support you to make sure, again, the time we have is quality time, that you can spend it with your family.
Does that ever come natural, or is that something that you're trained to do when you're in med school? And I'm just a curious guy asking these questions. Yeah. Do you get trained on how to have that conversation, or do you just get trained medically on how to handle it?
We do get training on it. I think there's good ways to do that. And pretty much every doctor you talk to has seen that conversation go badly. It wasn't well prepared and the reactions weren't expected. That conversation makes a huge difference in how that news is delivered and how the family's supported through that. They're starting to cope with that as soon as you deliver that news. And making sure we're doing that with empathy is huge.
So really, you're the quarterback, and depending on the diagnosis and the conversation you have, you're the one who chooses who you're going to throw the ball to next. Are you going to go to a radiation oncologist? Are you going to go to chemotherapy? Are you going to get surgery? You make that decision.
I like to think of cancer as a collaborative decision in that sense, or collaborative care. And if there's a question about, hey, do we think radiation can play a role in this? I'll pick up the phone and call the radiation oncologist and say, hey, here's the case. This is what's going on with my patient. Do you think there's a role in doing this to help them? So I pass the ball in a way, but really, I think it's a collaborative, we're all talking about you to make sure we're doing everything we can to help you.
And once you assign treatment or recommend treatment, and say it does go to a radiation oncologist or a surgeon, you mentioned earlier that you're with the patient every step of the way. Even though you've assigned them to a certain treatment, you still are the point on their team.
Always. I'm always going to be there. Once we've established that relationship, every time you see the radiation doctor and something's going on, they're going to pick up the phone and call me. And vice versa. If I see them and say, hey, they got radiation for this and this is going on, do you think they should come see you right away?
You know, we talked about the challenges of having the tough conversation with the patient.
Yeah.
In all fairness, we should talk about the other side, to where there are times that you get to have the best conversation ever with a patient.
Yes. And it is amazing because, again, you're part of their family, so you're celebrating on the inside and outside with the patient. Obviously, the patient feels amazing, but you get to celebrate that and feel so good that you've helped in that way.
I can just tell by talking to you, you're happy that you chose this to be a medical oncologist.
Absolutely. As I said, I tell people, medical students ask me, or undergraduate students ask me, do you like your job? I think it's the best job in the world.
Was this always your direction? Do you go to medical school to be a medical oncologist, or do you go thinking, I'm interested in this vertical, and then you realize that you want to be a medical oncologist?
Great question. Yeah. I actually didn't want to go to medical school. I thought out of undergraduate, I was going to be a lawyer. And then I ended up working in corporate law for a year and realized, nope, this is the exact opposite of what I want to do. I went to medical school and I changed what I wanted to do during medical school 5 or 6 times until I started working with cancer patients in a cancer clinic and doing cancer research. I said, this is amazing. And the strides we're making in this field, they're going to only get better and better. That's why I chose oncology during 3rd year of medical school.
So I come to you as a patient. You're my medical oncologist. We fight through it together, and I end up on the other end absolutely healthy. I imagine your relationships and friendships last for life.
They do. Absolutely.
When you say save a life, you're with them and probably their family and so on forever.
Yes. I know their son over in Georgia or whoever it is. We talk on the phone because we've developed that relationship through some very, very tough times for our patients.
How tough has it been with COVID and doing that first meeting?
I prefer to doing it in person. Mm-hmm. I feel worse about what's been going on in the hospital in terms of patients are coming in sick and having these conversations where I can't have another family member in the room and I have them on video on my phone or I have them on speakerphone. Your heart breaks. I wish I could have somebody in the room from a family holding my patient's hand. Obviously, I'm there, but I just met the person a couple of days ago. It's not the same as their wife of 40 years. It's been very hard to talk through that or take somebody through what's going on with the patient in these times.
As a medical oncologist, you have such an overview of cancer treatments in general. How do you keep up with all the clinical trials going on? And just tell me about your take on clinical trials.
Keeping up with literature is incredibly hard. They say medical knowledge is doubling about every 2 years. The best way for me to do that is journals. And then I listen to a lot of podcasts similar to this, where experts are discussing, hey, this is the newest thing, or this is the trial, or where when meetings happen, I listen to summary podcasts for those as well. Clinical trials, I think they have a very, very bad rap amongst patients and the general public. I think they're amazing. The idea of clinical trials is that we have something that's standard of care, meaning that's something normally what I would offer to you as the right treatment, and saying, well, can we add something more to this and potentially increase our response or increase our cure rates?
If somebody has a stage 4 and you have a chance at a clinical trial to get them in, a lot of patients would be willing to take that chance.
You'd be surprised, actually. A lot of patients have that connotation that clinical trials, I'm a guinea pig. It's the end of the line. It's not. I think clinical trials, especially for stage 4 disease, should be front line. It should be the first thing we consider. Is there something better than what we're doing? We have a 70% success rate for this. Adding this on, would it be a 90% success rate? Until we're at 100%, no medical oncologist, and none of us are satisfied until we can get rid of it, even in stage 4 disease.
You come from the Midwest, not too far from Chicago. And when you think of clinical trials over the years, we've heard Los Angeles and Chicago and New York and Dallas and San Francisco and the huge markets. Phoenix is growing now, and it seems like more and more clinical trials are coming out of Arizona.
They are. And I think the other part is clinical trials traditionally have been at big academic centers, so the patient had to travel somewhere else. One of the goals for myself and one of my partners in the East Valley, Dr. Dillon, we're trying to bring more and more clinical trials to the community. That way, you don't have to travel 50 miles to get to a clinical trial. That exceptional care and that availability should be available in your neighborhood. And we actually do have a couple clinical trials open for our patients.
I love Dr. Dillon as I get to know the Arizona Center for Cancer Care Family and Virginia G. Piper Cancer Care Network. You're in Gilbert and Chandler. Dr. Dillon and Dr. Patel and Dr. Tannehill.
Yes.
And you have quite the crew out there.
We have a great crew. I think when people meet us, we jive really well. We're calling each other all the time to discuss, hey, I've got this patient. It's a very open, collaborative effort, and I absolutely love it.
Let's talk about that for a minute, because as a medical oncologist, it has to be a big advantage to be part of a big group like AZCCC and Virginia G. Pfeiffer, because when you do recommend treatments, we have specialists already within
Yes.
Arizona Center of Cancer Care.
Yes, getting you an appointment with the breast surgeon. You're not going to wait 2 weeks or whatever it is to get in with them. As soon as we know we're referring you to them, because that's what we need to do next, I'm going to pick up the phone and say, hey, so-and-so, I'm sending this patient over to you. Can you please get them in within a couple of days or whatever it is? And a lot of times before my patient even leaves my appointment, I'm going to say, you're seeing them at this time on Friday.
We have covered a lot. It seems like I could do like 4 or 5 podcasts with you.
And I would love to do that. I think I really want to make sure that patients get everything out of their visits and understand what's going on with them. Hopefully at some other point, we can talk about terms like adjuvant, neoadjuvant, definitive, and things like that, just to walk you through what are those options. And you briefly talked about chemotherapy. Chemotherapy is not the only thing we use anymore. We've got immunotherapy, we've got targeted therapy, we've got oral. You could be treating your cancer with just pills.
Do you have time just to kind of go over some of those terms that you just mentioned?
Absolutely.
Because they're new to me and I want to understand what they mean.
Sure. When we think about treatment for patients, when I say curative intent, and that's something that at the end of our visit, when we're talking about treatment, you should know the answer to as a patient. Are we doing this to try to cure my disease, or are we doing this to control and buy that quality time we're talking about? When we think about curative treatments, you'll hear things like definitive treatment or adjuvant treatment or neoadjuvant treatment. Just to go through those, definitive means this is what's going to take care of the cancer definitively, meaning we're cutting it out or we're radiating it. The neoadjuvant part, adjuvant means on top. Neoadjuvant means on top but first. So a lot of times, somebody's got a big breast mass and lymph nodes. This is still something we can try to cure and we want to cure, but it's really big surgery. So we'll do neoadjuvant therapy, meaning chemotherapy or systemic therapy to shrink everything down or hopefully to get rid of everything we're seeing. So by the time the surgeon goes in, they get the sample and pathology tells me, hey, we saw no cancer there, which means that chemotherapy that went to that breast area also went everywhere else in the body, and any floaters that were hanging out also got killed.
And typically there's time to take those proper steps?
Yes, absolutely.
Okay.
I think that's the reason that when we meet, our patients should understand those options and say, should we be thinking about neoadjuvant or should we go straight to surgery?
I know a lot of people that must visit you, Doc, say, I have cancer, get it out.
Yes.
I don't want to take the first step and then the second step and the third. Just get it out of me, Doc. Do you have to encourage the patients to be a little bit patient?
Yes and no. I think understanding, and that's where making sure you understand what are our risks. Getting it out, yes, that's our goal at some point in this treatment, is getting it out or radiating it, whatever it is. But the bigger goal here is I don't want you to deal with this 2 years from now, 3 years from now. So it's a marathon, not a sprint. So if it means we should do chemotherapy because there's a high risk that this could come back somewhere else, let's do that up front. Shrink down everything we're seeing, kill off whatever else might be floating around, and then go after the surgery and then say, hey, we had great outcomes here. Our chances of this coming back are very, very low. I'll see you on a regular follow-up now.
What you do is fascinating. Is there any day that you are driving home and you're not thinking about your day and asking yourself, is this the perfect treatment? Going over it again in your head and over it and over it. It has to stay with you
all the time.
Is your wife in the medical field?
She is. She's a pediatrician, but it is always in my mind is, did I do the right thing for the patient? Is that the best thing we could have done? And again, that's where picking up the phone and running it through with a colleague saying, hey, I know this is pretty straightforward. I'm going to do this and this. Does that make sense to you? And they're like, yes, absolutely. That's exactly what I would do. And again, that's that collaborative feature of even just telling somebody else, hey, this is what I'm doing.
So your wife understands when you get those calls at 2 a.m?
Yes, she does. And she knows that we're here for patients and that's what we're going to do. So, and she sees the joy I get out of doing this job and she appreciates what we can do for our patients.
On the fun side of things, what do you and your wife like to do? I mean, music or sports or movies or?
We love movie. We're like big TV and Netflix people. The pandemic was probably we've been practicing for the pandemic for a long time in terms of Netflix. We were ready to go. I'm a big Office fan. That's what we love to do. And we love traveling. I think traveling has given us a perspective on the world and on human beings more than anything else.
Domestically or worldwide?
Worldwide. I think culturally, it's amazing to meet people from all across the world.
Where's the one place that you and your wife really want to go that you haven't been?
I think Africa is something we really, really want to do. And Vietnam, I've heard amazing things about it. I really want to go.
You know, I'd love to see Vietnam because I've just heard so much about it through history, and I want to put my eyes on it so that I have a better understanding of the atmosphere.
Yeah, everybody who's gone there raves about it. Food's amazing. The people are really, really nice. It's easy to travel. So I'm really looking forward to hopefully flying again in like a year or two when this pandemic is turned off, I hope.
In the meantime, Netflix.
In the meantime, Netflix, and there's Flagstaff, there's Payson. We can drive over.
You've been awesome.
Thank you so much for having me. I really, really appreciate it. I love the conversation we have.
I mean, I really worked you.
And I'm happy to. Again, I get to do this every day with patients. And I think you should bring all the questions you have to your oncology visit so we can run through it. And none of us are ever going to be tired of making sure we go through your questions and make sure you're comfortable with what's going on with you.
Just with your demeanor, I can tell that you're the kind of medical oncologist that would make a patient really comfortable and you take your time with them. What's the best way for them to contact you?
The best way to reach us is calling my office, 623-238-7540. You won't go through a phone tree. Just hit option 2 or option 3 and you'll get to a human being.
And if you guys go to ArizonaCCC.com, you'll see a tab that says Find a Doctor. Obviously, just go to Medical Oncologist and you can find Dr. Arun Singavi. Thank you so much.
Thank you so much, Dave. I really appreciate it. Thank you for having me here.
Thanks for listening, and please join us again for the Cancer Care Podcast, presented by Arizona Center for Cancer Care. For more information on the highest quality of cancer treatment in Arizona, please go to ArizonaCCC.com.